We start real life.
Yeah. Namaskar and good evening, everyone. I welcome you all for today's webinar on clinical updates from ASCO GI and GU 2025. With immense pleasure and honor, I would like to invite Dr. Abhishek Anand, sir, who is MD Medicine, DM, Medical Oncology, Senior Consultant, HOD, Paras HMRI, Director, Narayana Cancer Center, Patna, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you. Very good evening to all of you. And this will be clinical updates from ASCO GI and GU 2025. And on the day one, we'll be covering all the updates from the genitourinary ASCO 2025. And on day two, that is tomorrow, we'll be discussing on the important updates from ASCO GI 2025. So, can you let me share my slides? Okay, fine. For the first talk, I will be speaking on the paradigm shift in the management of muscle invasive bladder cancer. And
Sir, can you make it full screen?
that's fine. Start.
Yes, sir.
So, for the first talk, I will be speaking on the paradigm shift in the management of muscle invasive bladder cancer. And we'll be talking about the role of immune checkpoint inhibitors in neoadjuvant setting and the adjuvant setting of muscle invasive bladder cancer. For a long time, the important regimen that has been used in the muscle invasive bladder cancer as a neoadjuvant setting has been gemcitabine and cisplatin, or maybe dose dense MVAC and a few other important regimens. But incorporation of immune checkpoint inhibitors has come a long way in many other tumors, and now we are planning to incorporate the immune checkpoint inhibitors in the muscle invasive bladder cancer as well. We'll see the data of these immune checkpoint inhibitors in the locally advanced or early bladder cancer. So this is the global burden of bladder cancer, and if you see the 5-year relative survival for distant metastatic disease is 8.8, and for localized or regional disease it is 71.7% and 39.5% respectively. Global burden, total number of new cases is somewhere between around 6 lakhs. And if we talk about the deaths which happened in 2022, it was more than 2 lakhs. So it is the ninth most commonly diagnosed cancer and 13th leading cause of cancer related death globally. So, standard of care for all patients with muscle invasive bladder cancer has been radical cystectomy, and only if the patient is able to withhold this kind of surgery with a 50% cure with surgery alone, and it is highly dependent on pathological stage. Bladder sparing partial cystectomy should be done for patients like having solitary tumor in dome of bladder. Those cases are ideal, and the clinical outcomes is variable with highly dependent on patient selection. This is the NCCN guidelines that recommend neoadjuvant chemotherapy and radical cystectomy for patients who are stage 2, that is clinically stage 2 and 0, and muscle invasive bladder cancer. So we have to do the additional workup for all bladder cancer, which includes abdominal and pelvic CT or MRI, chest imaging with CT thorax or CT chest, bone scan or MRI if there are any clinical suspicion or symptoms of bone metastasis, and GFR to assess the eligibility for the cisplatin. Primary treatment, as recommended by NCCN, is the neoadjuvant cisplatin-based combination chemotherapy, followed by radical cystectomy, that is a category 1 recommendation. Neoadjuvant cisplatin-based combination chemotherapy followed by partial cystectomy, that is highly selected patients with solitary lesion in a suitable location, no TIS, or cystectomy alone for those who are not eligible to receive cisplatin based chemotherapy. So, this is the primary treatment depending on the patient and the tumor characteristics, and it has to be done followed by cystectomy. Subsequent adjuvant treatment is required only if no neoadjuvant treatment has been given to the patient, and if there is no cisplatin neoadjuvant treatment given and the patient has come as a PT3 or PT4A or node positive in the histopathological sample, then it is important to add adjuvant cisplatin based chemotherapy or should be considered an candidate for adjuvant nivolumab as well. The guidelines for stage 3A, that includes clinically T3 and 0, clinically T4A and T1 to T4A with node positive muscle invasive bladder cancer, remains almost the same. That includes the neoadjuvant cisplatin based combination chemotherapy followed by radical cystectomy. If the patient is not eligible to receive cisplatin based chemotherapy, then it is important to just go for cystectomy. Partial bladder resection is not advocable in this situation for patients who are stage 3 and above, and it should be followed by cystectomy and then subsequent adjuvant treatment. Of course, if no cisplatin neoadjuvant treatment was given, adjuvant cisplatin based chemotherapy should be given, and there should be a role of adjuvant nivolumab in certain situation. Chemoradiation has been shown as more effective versus radiotherapy alone for MIBC patients at high risk for complications from surgery. And in this trial, the authors concluded that further clinical trials are required to refine and improve chemoradiotherapy schedules uh, that are warranted, because we have got more robust data of neoadjuvant chemotherapy followed by surgery as compared to chemoradiation. But both of these protocols are being used equally nowadays. MIBC patients receive chemotherapy either as neoadjuvant or adjuvant treatment options, and there are pros and cons of both neoadjuvant and adjuvant therapy. Neoadjuvant, which is given pre-surgery, they destroy the micrometastasis outside the surgical field, and NSCT administered prior to radical cystectomy also reduces the risk of recurrence from the micrometastasis and may be more tolerable as compared to the adjuvant chemotherapy. Cisplatin-based NSCT is the recommended regimen for MIBC that provides a 5 to 8% survival benefit versus no NSCT. If we talk about the adjuvant setting, which is given post surgery in the cystectomy patients with extensive disease and MIBC patients who have not received an ACT and have non organ confined disease at radical cystectomy, may be treated with adjuvant cisplatin based chemotherapy. For cisplatin ineligible patients, some guidelines states that there is insufficient evidence for the non-cisplatin therapy, but there are few recommendation of using gemcitabine with or without paclitaxel. So these are the chemotherapy regimens which have been used as NSCT for muscle invasive bladder cancer, gemcitabine and cisplatin, which is used most commonly. Then dose dense MVAC, that includes methotrexate, vinblastine, doxorubicin, and cisplatin. Other cisplatin-based NSCT regimen that are used in the muscle invasive bladder cancer includes MVAC and CMV, that is for cisplatin, methotrexate, and vinblastine. Retrospective data have analyzed the difference between the gemcitabine and cisplatin versus MVAC, and They have shown almost comparable efficacy between these two regimens. So, because of lesser toxicity, we prefer to use gemcitabine and cisplatin more often as compared to the dose-dense MVAC. So, these are the toxicity and cisplatin ineligible criteria. So, coming to the role of immune checkpoint inhibitors in bladder cancer, the activity of BCG, which is a live attenuated bacterial intravesicular immunotherapy in non-muscle invasive bladder cancer, it provided the initial proof of principle that bladder cancer can be treated with immunotherapy. The high rate of tumor mutations in the bladder cancer results in environment suitable for immunotherapy, and higher mutation rates have been associated with increased tumor responses to immune checkpoint blockade in other tumor types. Together, these factors have provided the rationale for investigation of IO therapies for the treatment of MIBC. So, utilizing these background, a phase 3 checkmate 274 study evaluated nivolumab versus placebo for adjuvant treatment of MIBC. So, patients uh, with age more than equal to 18 years who have been underwent a radical surgery within 120 days of neoadjuvant cisplatin or ineligible for or declined cisplatin based chemotherapy with the evidence of urothelial cancer at high risk of recurrence as per the pathological state. They were randomized 1:1 to receive either nivolumab given at a dose of 240 milligram every 2 weeks versus placebo, with the primary endpoint being the disease-free survival. If you see the result, the disease-free survival was similarly improved in both the ITT population and the PDL1 population. If you see here the median DFS in the nivolumab, it was 21 months as compared to 10.9 months in the placebo. So it was a statistically significant improvement in the nivolumab arm as compared to the placebo. So nivolumab received FDA as well as a European medical agency approvals for patients with PDL1 more than equal to 1% in August 2021 and April 2022 respectively. There are existing unmet medical need in MIBC, and even after so much of advancement in the chemotherapy, there is a chance that 50% will experience recurrence or progression following radical cystectomy within 5 years. There will be a modest 5 to 8% decrease in the modest survival benefit from NSCT plus radical cystectomy, and less than half of cisplatin eligible patients receive NSCT. Apart from that, there have been no statistically significant improvement in the OS after the protocol we give neoadjuvant chemotherapy followed by surgery, and no treatment has improved further OS in this set of population. So, keeping all this in mind, we have got a very important trial, that is a Niagara study. It is a randomized phase 3 trial of neoadjuvant durvalumab plus chemotherapy, followed by radical cystectomy and adjuvant durvalumab in muscle invasive bladder cancer. This is the study design of Niagara study, and you can see here patients who were cisplatin eligible MIBC, that is clinically T2 to clinically T4A, node either 0 or 1, M0, urothelial cancer or urothelial cancer with divergent differentiation or histological subtypes. So these patients were randomized 1:1 to receive neoadjuvant chemotherapy, followed by radical cystectomy, followed by maintenance therapy. In the trial arm or the durvalumab was combined with gemcitabine and cisplatin, and in the comparator arm, it was gemcitabine and cisplatin alone. It was followed by radical cystectomy after 4 cycles, and in the adjuvant setting, durvalumab was given for 8 more cycles and in the comparator arm there were no further treatment given. The primary endpoints were event-free survival and path CR rate. The key secondary endpoint was overall survival. These are the baseline characteristics of Niagara study. The median age was 65 and 66 years respectively. Male were the predominant among the patient population in both the arms. ECOG performance status was 0 in 78% of the patients, and 71 and 75% of the patients were smoker in the two arm respectively. PDL1 expression was high in 73% of the patient in both the arm, and histologically 86% in durvalumab arm and 83% in the comparator arm were of urothelial carcinoma. Coming to the results, event-free survival by blinded independent central review team. If you see the median EFS, it was not reached for the durvalumab arm, and it was 46.1 month in the comparator arm. And if you see the 2 years event-free survival rate, it was 67.8% versus 59.8%. So it was significantly better for the durvalumab as compared to the comparator arm. Event-free survival sensitivity analysis also, it was better in the durvalumab arm as compared to the comparator arm. If you see the subset analysis, all the subgroup of the patients favored durvalumab as compared to the comparator arm, as you can see in this forest plot. Complete pathological response, there were two different types of analysis. Formal analysis and reanalysis were done in April 2024. We will see the updated analysis, and here you can see the complete response rate or the complete pathological response was 37.3% in the durvalumab arm, and it was 27.5% in the comparator arm. So it was higher in the durvalumab arm as compared to the comparator arm. Overall survival, if you see here, again, durvalumab had a better overall survival as compared to the comparator arm. And at the 2 year OS rate, if you see, it was 82.2% for the durvalumab combination, and it was 75.2% only for the comparator, where there was no durvalumab used. So if we categorize patients based on the path CR, so patients who had path CR, irrespective of whether we have used durvalumab or not, even then, among those patients who were enrolled in the durvalumab fared better as compared to patients who did not receive durvalumab. Here, in the subset of patients who had path CR, it was 92.1%, the 2 year survival rate in the durvalumab arm, and 85.8% in the comparator arm. For patients who did not receive any path CR, it was 53.3% versus 49.5%, the 2 year event-free survival rate in the durva versus comparator arm respectively. Similarly, the overall survival also was better in the durvalumab arm as compared to the comparator arm, irrespective of whether the patient has achieved a path CR or not. This is the overall survival subgroup analysis, and here also you can see the most of the subgroup of patients they favored durvalumab combination as compared to the comparator arm. Coming to the adverse event summary, if you see the comparator arm versus durvalumab arm, there were no new safety signals in the durvalumab arm as compared to the comparator arm, and the side effect profile was well managed. Only thing is that the immune mediated adverse events were slightly higher in the durvalumab arm, which was quite expected. And the most frequently reported adverse events overall were the nausea, anemia, constipation, fatigue, UTI, decreased appetite, neutropenia, pyrexia, diarrhea, and vomiting. In conclusion, Niagara is the first phase 3 perioperative immunotherapy study in MIBC and has demonstrated a statistically significant and clinically meaningful improvement in the EFS as well as OS. The EFS hazard ratio was 0.68 and the OS hazard ratio was 0.75, both of them being statistically significant. EFS and OS benefits with durvalumab were consistent across all the subgroups. The PATH-CR results and the significant OS benefits support the perioperative approach in the bladder cancer, those who are muscle invasive subtypes. Addition of perioperative durvalumab to neoadjuvant chemotherapy was tolerable and manageable with no new safety signals. Neoadjuvant durvalumab did not delay surgery and did not impact the ability of patients to undergo complete surgery. So Niagara supports perioperative durvalumab with neoadjuvant chemotherapy as a potential new standard treatment for patients with cisplatin eligible MIBC. These are few review of phase 3 IO studies in MIBC that are undergoing, and we'll be having the results of these trials very soon. With this, I would like to conclude my talk. Thank you so much. Thank you.
Thank you, sir. Thank you for the wonderful talk. Dr. Abhishek, sir. Dr. Prashant, sir, is present. So, can we invite him?
Yes,
Because till then, panelists will join, sir.
yes, sure.
So, sir, just invite Dr. Prashant, sir.
Hi, good evening. Can I share my slides?
Good evening, sir. Good evening.
Good evening, good evening. Uh,
So, we would like to invite Dr. Prashant Kumar, sir, who is the Chief Scientific Officer, CSO, Datar Cancer Genetics, Mumbai, and he is going to talk on panning for gold, the role of ctDNA as a biomarker for bladder cancer. Over to you, sir.
so first I need to share the slide, madam. So I'm just trying to find.
Yeah, sure, sir.
Uh, can you see my slides?
Yes, sir.
So is it coming full?
No,
Full?
so you need to make it full screen.
Can you see now full screen?
No, it's not yet full screen.
No.
Support team can be guide, sir.
Mhm.
Yes, ma'am.
Please guide, sir, to make the slide full screen.
Yes, the right hand side corner.
Uh, Sir, there is an option of zoom and right hand side bottom. There is cup. Please
Is
click on
it
that. Right hand side bottom.
right?
Right,
Extreme.
and bottom, sir.
Bottom, there's a screen, correct?
Yeah.
No, there's a screen. Yeah,
Can you move your cursor to the right, sir? Right hand side.
right. Yes, here.
It's more right, sir. It's extreme. You can see there's a zoom option. Zoom. plus minus. After that, there is a cup is there. Please click on that cup.
Right hand side corner.
Right side corner, there's nothing I find. Hello, can you see? Can you see now?
Or from above. So you can go from the above also, slideshow mode.
Hello, sir.
This slideshow is there.
Sir,
Yeah.
right hand side bottom. There is option in zoom in, zoom out. Right hand side bottom. Yes, yes, yes. Sir.
Yeah.
Not, yes. Yes, yes. This one.
Can you see now? Full no. Hello.
Sir, it's still not full screen.
So left hand side corner, top home button, then slideshow. Open side slideshow.
Do we have, sir? We can share from our
Yeah, so
end. If
ma'am,
you,
I have a slides. So I'll just share if you want. So I'll share from my sides.
You have the slides? You don't have the
Yeah,
slides.
I have.
Okay.
I'll just share from my side, sir.
Dhruv, we don't have sir slide actually. Sir
No,
has made it.
you don't have. You don't have my slide. That's where I was surprised.
Okay. Yeah.
See, I am on the screen. Only thing I need to figure it out why this is not happening full screen.
so you can see the top side where it is written design, transactions, transitions, animations. Beside animation, there is one option slideshow.
Yeah, slide
Just
show.
click, yeah, on top.
Yeah,
There
slide.
where you have home, insert, design, transitions, animations.
Yes, sir.
Yes,
Click
yes,
on that button.
that button.
Click
For
Yes.
on the
slideshow.
slideshow.
Yes. Yes.
From beginning.
From
Yes,
begin.
click on this.
Yeah, I clicked
From
it.
the beginning.
First option, sir.
Yes.
Yes.
It came.
No.
Sir, you need to share again.
Okay. I'm so sorry for the hiccup. I think I should have
It's okay, sir. It's okay.
checked it in advance.
Sir, can you share it again now?
Yeah, I'm doing it. It just. Yeah, and then I'll go to. Can you
Yes,
see?
sir.
Yeah.
Go select the from beginning option. First option on the left. Below home, below file.
From beginning.
From current slides, yes, insert.
Yes, sir.
Left
Click
hand
there.
side there is a
Click on that.
below from beginning. From current sides, if you see left hand sides written from beginning.
So here in design, insert home, animation slideshow, I go from beginning. Yes. Can you see now?
So you have stopped share. So can you just share it with us, sir? We'll show from our side.
Yeah, I'm sending you the slide. Can you share me the email address?
Sure.
Just wait, sir.
I will guide you, sir.
Yeah,
can
please,
see?
please.
Can you see the screen?
Yes.
Yes, sir. Now you need to click. Can you see my cursor?
Yeah, I'm doing there only. It is not happening. That is, I'm surprised by.
Now is it full screen?
So it's done. It's on full screen.
Sir, it is full screen now? You
Yes,
can start, sir.
full screen, madam, but I cannot see my slides.
Okay.
I cannot.
I have shared you the email ID and chat, sir. Please share your slides on that email ID.
Yeah, can you see my slides? And then I can. Yeah, can you see my slides now?
Yeah, we can see, sir.
Full slides. Full.
Yeah,
Okay.
full.
Yes, sir. Now it is full screen.
Okay. But can you see me changing? No, it's changing.
No, sir. First you click on somewhere, click on Kanpur, and then you can change the slides with the arrow keys.
No, this slide I'm trying to make it bigger.
Sir, your slide is already in the full screen. You come
Yeah,
back.
but the only problem is that I am not able to see my bigger form of slide. It's coming a small window of my slides. Oh God.
Sir, you need to come back to Zoom. You are actually in the presentation.
Yeah, so I will go
Your
to.
Zoom is minimized.
Okay, so I will go to screen.
Now, can you change it with the arrow keys, sir? Sir, click on the screen, anywhere on the screen, on your
Yes,
slides. You are
yes.
in Zoom, right?
There's no. There is.
Sir, can you share it in the chat box? Share your slides. I'll share it from my end.
Yeah. Can you just give me the email address quickly? It will happen. Where is the email address? Can you just share me? Can you share me the email address?
Sir, it is already in the chat box. Can you see the chat box?
Sir, through WhatsApp, sir, email ID.
Yeah, I got your. Yeah. Please share the email address now, chat box. Yeah, I got it. Hello.
Yes, sir.
Yeah, I sent you in the mail.
Just a minute.
Jenny, can you send me my presentation on the WhatsApp quickly? Because I'm not able to connect and they're waiting. Quickly send me. Hello?
Hello. So actually, I haven't received your slides yet.
I'm so sorry. It is just mess. I'm sending you on the WhatsApp on the same site. I'm
Okay.
sorry, everyone. Everyone, I'm so sorry.
No issues, sir. No issues.
Yeah, I shared you there.
Sir, can you see my screen? Prashant, sir?
Yes. Yeah. Yeah, just a second.
Can
Yeah.
you change?
Yeah.
Yeah, you can start, sir.
Yeah. Hi, everyone. I'm so sorry for the hiccup and really, really sorry for what has happened. I must thank Dr. Abhishek Anand for this for the invitation. I have been asked to speak about panning for gold, the role of ctDNA as a biomarker for bladder cancer. Can you go please next slide? Yeah. So this slide summarizes that what are the current testing methods we are using in the lab. And all of you know that the cytology is something which we still believe, and urine cytology which has lower sensitivity and specificity. However, we believe on imaging examinations, cystoscopy, which is routinely used from the tissue biopsies, and liquid biopsy is something which has evolved in the recent years. And I would say that last 1 decade, if you see the tremendous amount of data which have been produced in terms of liquid biopsy. And when we talk about the liquid biopsy, it covers any form of biological material which could actually eventually give the similar kind of information what we would eventually get it from the biopsy sample. So what liquid biopsy is that anything which you can get the biomolecule in the liquid solvent, and it could be either link RNA, mRNA, circulating tumor cells, exosome, and ctDNA. Next slide. So I would focus on the ctDNA, and why? Because this is a very relevant discussion and the presentation where it actually this slide shows that how the ctDNA sensitivity, if you see across the cancer, you'd find that the bladder cancer, which has actually more than 0.6, so it's a 60% sensitivity. So what does it mean? That every time if you use the liquid biopsy in bladder cancer, your success probably will be almost 60%. And that's compared to, if you compare with the prostate and lung cancer, it is much higher. Similarly, for AF, which you could see the variant frequency or allelic frequency, what we call it, you could again see. Can you just tab it, the slides? You go for the next tab. Excuse me. Yeah. So what you would see that the bladder cancer again, the allelic frequency, which is almost higher, so something between 1 to 10%, and again the TMB, what you see compared to lung cancer, the TMB or the tumor mutation burden is much higher in bladder cancer compared to many other cancer types. Next slide, please. So ctDNA, when we talk from where the ctDNA components are coming, and this slide shows very clearly that the ctDNA, the origin is from blood. When you take the patient's blood, there are different kind of tubes which we use routinely in the clinical setup, in the lab setup, and this is where you can see that it started with the EDTA tubes, but then we realized that many times it's very difficult for the shipment of this ctDNA, which adhere, actually the cells adhere the ctDNA, and this is where there are many cell stabilizing tubes which are used currently, which include extract tube and the PAX gene blood tubes, and these are the tubes which has capability to store the cells for more than 10 days to 15 days, and this will be very convenient for the shipment process. The process of isolating ctDNA is very simple. You just centrifuge the blood, and if you centrifuge the blood, you would see there are three different components: the RBC, which is in the pellet side, and at the plasma on the upper side, and the Buffy code. And this is what you can see. It's represent in the plasma almost 55%. You would identify in the plasma where you will identify the ctDNA. Now, once you have the ctDNA, what you need to do is you will go for the NGS. The NGS could be either NGS based technology, where we employ either for whole exome sequencing, targeted sequencing, or you can do much more focused PCR based sequencing. Eventually, what it gives you, the genomic coverage, which would include the mutation, which is called single nucleotide variants, copy number variants, which is called CNVs, fusions, and methylation pattern. Next slide, please. So this again eventually shows that how tumor informed and tumor agnostic ctDNA analysis, which is currently used, it clearly shows tumor agnostic, where you use generic test to detect specific cancer alterations. That is where it is called tumor agnostic, where no need for primary tumor analysis, and this is based on the fragmentomics or methylation analysis, and this is again used for screening and detection of the mutation. The tumor informed to the right side, you could see, which is more sensitive and specific. It's a better validation during the, of course, neoadjuvant chemotherapy or any MRD monitoring. And this is
Hello. Hello.
Hello. Hi, Dhruv. Can you hear me?
Yes, ma'am. I can hear you.
Uh, I'm from Prashant sir's team, so there is some power issue with him.
Okay. Hello.
Hope he will be joining soon. Let me connect with him once.
Sure.
I'll update you.
Sure.
He will be joining back in
Sure, ma'am.
Okay.
Hello. Hello.
Hello.
Can you hear me? I think
Yeah, yeah.
today is a very difficult time for me. The power never got disconnected, but now power got also disconnected for some time. I'm so sorry. By the time,
No issues, no issues. So, you can see my slides. You can see the
yeah,
slides, right?
I can see. Yeah. So I'll just go ahead. So I was just discussing about the different modes of ctDNA analysis, and this is a very interesting slide where there are different companies who have developed the different methods for the analysis of ctDNA. What you would see that there is a test which is based on the methylation analysis or methylation pattern, and which is called Galleria, which is tumor agnostic testing. While another test where Guardant has developed, which is tumor agnostic again, and this is used for ctDNA method, which is also used for MRD testing, and it is combination of both methylation analysis and next generation sequencing on the ctDNA side. There's another test which have been developed by Signetra, and this is again based on the Amplicon based or NGS based method. There is a separate identity which is called droplet digital PCR, which is much more sensitive. And again, ddPCR also you could use for ctDNA sequencing and analysis of a variant on the ctDNA. Next slide, please. Excuse me. Yeah. So now, what are the implementation of ctDNA based MRD detection in routine clinical practice? And MRD is something which I don't think so. I need to go much detail to explain you. Minimal residual disease, which is something very recently it has been came in the focus, that how you can actually utilize the ctDNA based information to identify the MRD. And this is one such example where you can see that the patient at advanced stage, where you can do the longitudinal collection of the blood sample and identify a mutation or mutation pattern. Another ways would be that the patient requiring surgery and follow-up treatment, where you could see the blood would be collected before surgery, after surgery, and then again you would do the baseline before treatment sequencing, landmark, which is after a definitive treatment, and longitudinally, which could be every 3 to 6 months. The third way, where the patient requiring the neoadjuvant and further treatment, and this would again be before surgery. The patient will be given the neoadjuvant, and then you are collecting the blood at the baseline, after the treatment and post surgery, and this would again give you the status, which is called MRD status positive. Once you get the MRD status positive, it means the patient are on high risk of recurrence. It also reflects the poor prognosis of the patient who are undergoing chemotherapy and
I think we have lost him again. Summer, can we call Dr. Prashant?
Yes, ma'am. He has some network issues. He's joining again.
Okay. Hello. Dr. Abhishek Anand, sir. Hello. Sir, I think Dr. Prashant is having some network issue. Hello. Dhruv, stop sharing. I think there is some network issue at his end. Hello, Dr. Abhishek Anand, sir, are you there?
Just call him once.
Sir, we have, I think there is a
Yes, yes.
network
Just
issue.
call
So,
him once.
okay, so we need to wait, right, sir? Just call someone.
Yes, just call him once again. Okay, and
Hello.
Ma'am, he's not picking. Okay, sir is joined.
Sir has joined. Yeah. Sir is there.
I think this is today is the very bad day because power came, power gone. My battery got disconnected and everything happened. So, and I don't know how many of you are getting my points, but today I think it's the first time this happened. Never had happened before. Anyway, so sorry. I hope I'll quickly complete before it will again
Yes.
have any interrupt. So this is actually showing the implementation of ctDNA based MRD detection in routine clinical practice. And I was just mentioning that the way we use ctDNA, we would do either for the neoadjuvant setting or adjuvant setting. The idea is that if we can identify the MRD status positive or negative, if MRD status comes positive, which shows us that it's a highly recurrence possibility and worse survival and more aggressive therapies would be needed. However, when MRD status negative, it means it's a low risk, better survival and follow up or de-acceleration of the therapy. Next slide, please. So I would so these are the slides. Okay, again. Yeah, I'm not able to see my slides also. So this, yeah, hello. This is ctDNA as a predictor of immunotherapy response in urothelial cancer. And this is one such beautiful study which was published in Nature 2021. What it shows that the patient who have been given atizo, so with and compare with the patient who were post surgery who was on the observation, what you would see that the patients shows uh, when the patient become positive to negative for the ctDNA or negative to negative for the ctDNA, they have far better survival compared to the patient who become positive to positive for the ctDNA or negative to positive. And this is what you can see in this graph, Kaplan-Meier, where survival it correct and connect very clearly. And this also shows that when you see this particular graph, you could see that 18% or 18.2% where the atizo has been given, and you can predict based on the ctDNA. While the other group where the patient has not been given the immunotherapy, where 3.8% you could see the response. This also reflected to the right side where probability of the overall survival, again you could see end to end means negative to negative have much more longer survival compared to any other subtypes. Plot D, which is bar graph, and it is showing the fraction of patient which is pre-treatment, post-treatment, and responders between non and compared to non-responder, which have been given a new adjuvant trial study, which is called ASCO. And you would see that pre-treatment there is ctDNA positive versus negative is a much higher ctDNA negative post-treatment compared to the patient who are non-responders, and ctDNA clearly correlate with the responders and non-responders. Again, in the graph E, you could see pre-treatment, post-treatment, and the ctDNA concentration, which was much higher post-treatment, the ctDNA concentration gone much down, much reduced in responders compared to the non-responders, where the ctDNA concentration was almost similar. Next slide, please. This is another study, and this is again in the bladder cancer, where ctDNA detection, prognosis assessment in patient treated with NAC. So it's a non-adjuvant chemotherapy, and what you would see again, the recurrence-free survival before ctDNA, before RC, and after RC, you could see that the survival is much higher compared to the red ones, which is again, if you see ctDNA before and after, in both the cases, negative and positive, you would identify that ctDNA before recurrence-free survival is much higher, which is you could see 70%, compared to no recurrence, where the concentration or the fraction of the patient was much higher in case of negative. And similarly, you could see down where the ctDNA after recurrence-free survival and ctDNA compared to both the cases where ctDNA fraction increased post-treatment in the recurrent patient. Next slide, please. This is a beautiful study again where it has been compared the ctDNA with the tumor tissue DNA in metastatic bladder cancer. To the left side, what you would see that this is showing the genomic alterations pattern, which is the upper side, which is coming from the ctDNA, and the lower side bar graphs showing the all the tumor alterations, which is from the ctDNA. And what you would see that most of these analysis, and if you go from left to right, the multiple mutations have been mentioned, which is starting from p53 and KMT2, RB1 and ATM. So there are multiple mutations, and if you see the way ctDNA capture the mutation frequency, which is much more concordant with the tumor tissue. And again, it is showing the small box, which is showing the pathways, and PIK3 CA pathway, AKT1, P10, which is also, again, you could identify both in the ctDNA as well as in the tumor tissue. Right side, it's showing the uniformity. You can see the kind of mutations which have been identified both between CTCs and ctDNA and the tumor tissue. It's very linear graph. And again, in the tissue, again, you can see the if we compare the tumor mutation burden between the ctDNA and primary tumor tissue, it's showing the linear graph. Uh, Again, right to the down, you can see the overall survival for the self-free DNA collection, low ctDNA versus high ctDNA, and the moment the ctDNA goes up, you could see the poor survival. And this actually signify that the blood correction and low ctDNA versus high ctDNA concentration, and this is where 17 patient out of 71, and high concentration where 54 patient was identified out of 71, and this reflects that high tumor proliferations where the ctDNA concentration was higher, and it also reflects the poor prognosis compared to where we identify low ctDNA concentration, which actually indicate low tumor proliferation and good prognosis. Next slide, please. This is another beautiful study, and this is real world data. What you would see that it's a bladder cancer again, and the patient has been actually given after first scan a neoadjuvant chemotherapy. You would see the tumor size increasing, and you could see again it has been given in the red dots when the patient has been called. Again, the second scan has been done, and what you would see that in the neoadjuvant chemotherapy where the patient has been given gemcitabine, cisplatin, surgery has been done, and again the adjuvant immunotherapy has been given. And what you would see here that how the ctDNA concentration has been decreased. This is what you can see, mean tumor molecules or the burden, which post pembrolizumab it has been reduced, and this is well reflected with the scan where the size of the tumor has been reduced. And this is one beautiful example where it shows that how can you use ctDNA in bladder cancer, especially for the monitoring of the patient, and based on that you can take the call if the patient is responding the treatment. Next slide. So yeah, so this is one such a study which we have. I'm just showing you data from the Datar Cancer Genetics, and this is where we use liquid biopsy to monitor a patient disease progression, and this shows trends in mutant allele frequency. This is 88-year-old male patient, a case of urinary bladder cancer, and there you could see the multiple mutations we have identified based on the ctDNA. It's KIT, T53, FGFR3, which is well-known mutation, in bladder cancer, and especially for muscle invasive bladder cancer. And you can see the variant S371. There are two different variants we identified, and T53, of course. So what you should see to the right side, uh, the mutation load and the when the patient has been presented, and when we have done multiple set of sample where the blood has been collected and the sequencing have been done, what it shows the data at 12/11/2018, where we didn't identify any mutations. Following up the patient at 15/5/2019, so almost 6 months later, patient has developed the mutation, and this is where you can see the different kind of variant frequency. For the kit, it is given T53 0.1, FGFR3 0.1, and another variant of P53 we couldn't find. Again, the patient have been followed, and then the patient, again, the blood sample have been collected at 7/11/2019, so after almost 6 months, and then we couldn't identify any mutations present. Patient has been followed again after almost a year time. There was no mutations, and again after 2 years, patient have been follow up, and the blood sample have been collected, and you could identify only T53 mutation. So this is one such beautiful example where we would stress that how can you use the ctDNA based monitoring, and could identify, and based on those monitoring you can actually uh, uh, give the treatment what had been identified on the ctDNA, and you can maneuver the treatment based on the results which you would identify based on the mutational landscape based on ctDNA. Last slide. I think I'm about to finish. This would be my last slide. Can you please? Yes. So ctDNA dynamics, I was just trying to convince you that how ctDNA could be used. You can use ctDNA for MRD, you can use ctDNA for monitoring, you can use ctDNA in every setup. It is starting from baseline, new adjuvant setting. But what eventually it gives you, the dynamics, is that you can understand the biological factors. You can also biological factors means you can identify, of course, if the tumor is growing, if the tumor is proliferating, if there's immune filtrations. The another set would be that you would also see the patient response and the outcome, which could be progression free survival, recurrence, metastasis, overall survival, and pathological response, which I showed you the example between non-responders and non-responders. Biological insights, of course, the mechanism of resistance, and that is what you have seen that some of those longitudinal sample we identify some novel mutation which have been developed, MRD, and of course the sensitivity, and the last, that based on these all uh, profiling on the ctDNA, we would definitely maneuver the treatment, and the treatment could be based on the mutation we identify. And immunotherapy, I had given some of the beautiful example where immunotherapy was given to the patient, and based on the ctDNA mutation or the ctDNA load, and it actually implemented very well with the current status in bladder cancer. Thank you so much for your attention, and I'm again sorry for the hiccup. Actually, I was so nervous because of these hiccups, and I think I really derailed my presentation, but I'm so sorry for this. Thank you so much.
Thank you, sir. Thank you so much for the excellent talk. And next, I would like to invite Dr. Tamojit Chaudhary, who is medical oncologist at Apollo's Hospital, Kolkata, for the talk on adjuvant therapy in renal cell cancer, a practical guide. Over to you, sir.
Yeah, good evening. Hope I am audible and visible.
Yes, sir.
Kindly share the slide deck. Thanks to organizers, thanks to Dr. Abhishek, who is my dear friend from DMTS, for this invitation. Am I audible clearly, na?
Yes, Tamojit, you are audible.
Yeah, thank you. So for the next 10 minutes, I'll try to discuss and all the fine facts regarding the adjuvant systemic therapy options for renal cell carcinoma post radical nephrectomy, predominantly in the high-risk population as per the UISS scoring criteria. And we all know that if we focus on the current NCCN and European Medical Agency EMA approvals and guidelines, then except pembrolizumab, there are no other category 1 recommendation for adjuvant therapy of RCCs post radical nephrectomy. And way back in 2016, there was an approval for sunitinib, but presently not sunitinib, but any other anti-VEGF TKI is also not preferred in the adjuvant setting. We'll try to dissect out what are the major reasons for for this failure of anti-VEGF TKIs, which are pretty much effective in metastatic setting, but these are not so effective in adjuvant setting, as well as what are the current evidence and updated data for pembrolizumab, and probably we need better systemic therapy agents, and what are the way forward or the future trial directions that also I'll be covering in the short span of time. So any issues with the sharing of the slide deck? Slides are not visible to me.
Can we have to share the slides, sir?
Yes, yes, please.
Yeah. Dhruv, please do the needful.
So you can see your screen is visible.
Perfect, perfect. Thank you. So there is one typo error. I am attached with Meherbai Tata Memorial Hospital, Jamshedpur at present, not at Calcutta anymore. So as discussed, we'll try to dissect out the various adjuvant systemic therapy options for renal cell carcinomas, and this is going to be the roadmap for today's discussion. So why there is a requirement for an adjuvant therapy, particularly in high-risk population, what are the data regarding TKI-based therapies, and what are the landmark data for adjuvant immunotherapy with pembrolizumab, and probably with other immunotherapy agents are also, and what is probably the best option for a future trial designing for an adjuvant systemic therapy in renal cell carcinoma. Next slide. So interestingly, in spite of angiogenesis and tumor heterogeneity are important attributes for renal cell carcinoma, at least for the primary tumor. But as discussed, and that I'll cover in subsequent slides also, that anti-VEGF TKIs, which are pretty much effective for first and subsequent line of therapy in metastatic setting, these are not so effective in adjuvant setting. And as well as these are highly immunogenic tumor, we all know that, and that is probably responsible for a high effectivity for adjuvant immunotherapy options in high risk scenarios. Next slide. Next slide. Yeah, so what should be an ideal optimal adjuvant systemic therapy option look like? So there should be an improvement in the overall survival, a maintenance of the quality of life of the patient, and not just delaying the relapse. So that means there is no lead time or lag time bias. There should be a true improvement in the overall survival, no long-term toxicities, and what should be the ideal duration of adjuvant therapy that probably at the moment we are not know in a very robust fashion, and as well as the availability and finances. Next slide. So why there is a requirement for adjuvant therapy? Because 20 to 50% of the localized RCCs are eventually develop metastasis after radical nephrectomy. 5-year overall survival is, which is as high as 93% for stage 1, stage 2, but this is roughly around 70% for stage 3 disease. That means 30% of the stage 3 RCCs post radical nephrectomy succumb to the disease within first 5 years post surgery. Next slide. So this is an important slide. This is basically different nomograms to detect who are the actually high-risk population in localized renal cell carcinoma post-radical nephrectomy. There are 4 different models as mentioned in this slide, but probably the most important and most commonly used high-risk criteria definition for high-risk criteria is used as per the UISS model, at least as per the major clinical trials are concerned. Next slide. So understanding adjuvant clinical trial in renal cell carcinoma is important because as will be discussed in subsequent slide, that we know that the control arm is always a placebo, at least as of now. And we choose high risk population based on certain criteria. We give certain sort of experimental therapies. And the primary endpoint in most of these trials are actually disease-free survival, which is basically a surrogate for overall survival. But whether disease-free survival is a true surrogate for overall survival in high-risk adjuvant renal cell carcinoma, that question need to be answered in a robust fashion. We really don't know that. Next is there is a lot of difference between informative censoring percentage between the control arm and the experimental arm in the major trials, and that is one of the limitation. Third is what should be the optimal post-progression therapy, particularly for the control arm. That's again an issue, and again a major limitation for the majority of the trials. Next slide. So interpretation of the trial, as we have discussed, the DFS, whether it's a valid surrogate for overall survival, we don't know, at least in a robust fashion as of now. Second is informative censoring. The percentage of informative censoring is different between the experimental and the control arm, and the optimal therapy post progression and post recurrence in the control arm, again, that is a limitation of the majority of the trials. Next slide. So evolution of the adjuvant clinical trials in the RCC, these are predominantly being tried in high risk UISS score patients, and initially tried with various anti-VEGF TKIs, including sunitinib, sorafenib, and pazopanib. And later on, various immuno-oncology drugs also been tried. And probably the way forward is an immuno-oncology drug, plus additionally, either an VEGF TKI or a different combination of immuno-oncology drug, which may be a CTLA-4 inhibitor, which may be a LAG-3 TIM-3 inhibitor. So probably future trials will give the answer. Next slide. So these are the major anti-VEGF TKI adjuvant trials. As we can see that we have data for sorafenib, sunitinib, and pazopanib and axitinib. These are 4 landmark phase 3 trials. The control arm is always a placebo adjuvant therapy given for various UISS high risk or sometimes intermediate risk patient for 1 year of anti-VEGF TKI. So unfortunately, out of these 4 trials, only extract data, which is the sunitinib for 1 year at standard doses for a high-risk population, means more than equal to T3 disease or N plus disease. The primary endpoint is significantly better, which is the DFS. But all other trial data, the primary and secondary endpoints are not significantly better, favoring the experimental arm. Extract, unfortunately, although the primary endpoint is significant, but in the longer follow-up, the overall survival is not significant. Next slide. I believe this has already been discussed. Next slide. Yeah, so this is the design of extract study. 1:1 randomization between standard dose sunitinib for 1 year versus placebo for 1 year. High risk UISS scored patients have been enrolled. That means anything which is more than equal to T3 disease or any N plus disease. Primary endpoint is significantly better, favorable on the sunitinib arm with a hazard ratio of 0.76. The median DFS is roughly around 6.8 years for the sunitinib arm versus 5.6 years for the placebo arm. But unfortunately, the longer follow-up, the OS was not seen. So this trial was basically the basis for FDA approval of adjuvant sunitinib with a category 2A recommendation way back in 2016. But unfortunately, with a longer follow-up, we know that the OS data failed, and eventually there are a lot of other criticisms of this extract data. Predominantly, the side effect profile is not significant for an adjuvant study for an adjuvant drug, which is roughly around 58% grade 3-4 side effects, 28% patient not completed therapy or permanent discontinued due to toxicities. So all these criticisms, and the major criticism is there is a conflicting evidence between 2 different sunitinib trials. One is the ASSURE study and one is the extract. So eventually in 2019, the FDA approval is not for a very preferred option for adjuvant therapy, and that's there is a need for adjuvant trials with separate systemic therapy agents, predominantly immuno-oncology trials. Next slide. So this is again a landmark study, the adjuvant pembrolizumab for high risk UISS scored patients with renal cell carcinoma post radical nephrectomy, published in NEGM in August 2021, and that is the major basis for the approval of pembrolizumab for this particular indication with a category 1 recommendation as of now. Next slide. So this is the design, again 1:1 randomization between pembrolizumab 200 mg every 3 weekly for 17 cycles or 1 year of therapy versus placebo is the control arm. Patient enrollment criteria we'll discuss in subsequent slide. So the primary endpoint is DFS, secondary endpoints are OS and other toxicity parameters. Next slide. So this is basically the eligibility criteria or enrollment criteria for patients. This is as per the UISS scoring nomogram, which included intermediate to high risk population as well as highly selected oligometastatic disease post R0 resection and no evidence of disease at the time of randomization. So intermediate to high risk disease means any pathologically T2 disease with a grade 4 or sarcomatoid differentiation, or T3, T4 disease with a N0, M0 status, or any N plus disease, irrespective of the T stage. And as discussed, the very high risk population would be M1 with no evidence of disease. That means highly selected oligometastatic disease with the R0 resection of both the primary and as well as the metastatic sites. Next slide. So this is the primary endpoint, the DFS again significantly better, favoring the experimental arm, the pembrolizumab, with an hazard ratio of roughly around 0.63. Next slide. So, as discussed, this included 3 different risk criteria patients as per the UISS scoring. So the intermediate high risk is the major chunk of the study population, which is roughly around 90% of the chunk. The 5% is high risk population, and M1 disease, oligometastatic disease with no evidence of disease, means arterial dissection, roughly around 5% of the ITT population. So what we can see is that the hazard ratio is significantly better, favoring the experimental arm in all these 3 subgroups, with a statistically significant cutoff as per the predefined level. Next slide. And when we do the subgroup analysis based on the next slide. Slides are not moving. Am I audible? Yeah, perfect. So this forest plot suggested that all the predefined as well as the exploratory subgroups, the experimental arm is favorable for the disease-free survival. Next slide. Just like the primary endpoint, the significant secondary endpoint, which is the overall survival, is again statistically significant in the longer follow-up. Next slide. That 48 months of follow-up, or almost 4 years of median follow-up, the difference is roughly around 91% for the pembro arm versus 86%. So roughly around 5% difference, favoring the experimental arm in terms of overall survival at 4 years, which is statistically significant. Next slide. Interestingly, except pembrolizumab, none of the other immuno-oncology drug trials at this moment have shown any DFS or OS benefit, including nivolumab, including atezolizumab, and including nivo-EP combination therapy. Next slide. So there are a lot of systematic reviews and letter to editors regarding what should be the ideal adjuvant therapy option for renal cell carcinoma. Next slide. And next slide. So gist I'll explain in subsequent slides. I believe this slide already been discussed in initial part of the presentation. Next slide. Yeah, so there are many key issues with the Keynote 564 data also, the pembrolizumab data also. The major 2 issues are, number one, the duration of adjuvant treatment, which has been chosen for 1 year for immuno-oncology drugs, is actually a replication of the prior anti-VEGF TKI trials. So whether the adjuvant 1 year of pembrolizumab is sufficient enough, or it should be given for at least 35 doses or 2 years, just like in other adjuvant trials of immunotherapy, we really don't know the answer to this question. The next limitation or major issue is the Keynote 564 is the significantly different level of informative censoring or dropout between the study arms, between the experimental and the control arm. Next slide. Next slide. Yeah, so probably the ideal future. So the real question is, do we need a better option for particularly for high risk and very high risk patient of renal cell carcinoma post radical nephrectomy? Obviously, the answer is yes. We want better results. We want better overall survival, something which is near about 90% for a stage 3 high risk disease. And at the moment, this is not feasible for at least pembro monotherapy arm. So probably we need better combination regimens with immuno-oncology drug and some other agent like belzutifan. There is ongoing trial in the form of LightSpark data. We know that belzutifan is basically approved in a 3rd line and beyond setting in metastatic renal cell carcinoma, and there is ongoing trial with pembrolizumab combination of this drug. The next ongoing trial is durva tremelimumab, again anti-PD-L1 and anti-CTLA4 inhibitor drug. We know that this combination can do wonder, particularly in highly immunogenic tumors. So probably the final results of these 2 trials will give a lot of unanswered questions. Next slide. So as discussed, what should be the ideal duration? Whether 1 year is enough, or it's too much, or it's too short, we really don't know. Probably whether we need better dose intensity regimens, combination regimens, which is some other agents over and above pembrolizumab or over and above immuno-oncology drugs, that again the question need to be answered. And probably the best way forward is adaptive trial design, and depending on the real-time monitoring with the disease recurrence or early disease recurrence with the ctDNA or methylated DNA monitoring, as well as based on better risk stratification of this disease based on the angiogenic or immune signatures. Next slide. So this is the last slide. Shared decision making is the key. And so as of now, pembrolizumab has a category 1 recommendation for clear cell renal cell carcinoma with pathologically T3 or higher disease. M1 disease means highly selected oligometastatic disease with no evidence of disease at 1 year after R0 resection, and even with sarcomatoid component. So the main limitations of keynote is that we don't know that how much this adjuvant therapy will work for a non-clear cell histologist, and choice of first line therapy for after progression for this 1 year of adjuvant pembrolizumab, that again need to be answered in subsequent trial.
Thank you, sir. Thank you so much for your excellent talk. And next, as we move forward for a panel discussion on management of oligometastatic prostate cancer. For this, I would like to invite to moderate the panel Dr. Abhishek Raj, sir, who is Senior Consultant and Head, Medical and Hematology, Sarvodaya Hospital, Faridabad. And panelist for this panel, I would request Dr. Rajesh Patidar, sir, to be the panelist for who is Consultant Medical Oncologist at Indore. And I would request Dr. Tamojit sir and Vipinesh sir to be the part of the panel.
Good evening. Good evening, all the panelists. Thank you, Dr. Abhishek, for inviting me for this conference. And the topic I was given was oligometastatic, but I think the panelists, most of us are medical oncologists, right?
Yeah, all are medical oncologists.
So that is why I think I decided to change some of the presentations, because it would have been nice if we had radiation oncologist as well as the surgeon also on the team. So let's discuss some of the key aspects of metastatic hormone sensitive and castration resistant sequencing of the therapy, some of the key problems that we will have. So I think we have Dr. Rajesh, we have Dr. Tamojit, and who's the third panelist? I'm sorry.
Dr. Vipinesh, sir.
Okay, so all of us are here. So quickly start with a 66-year-old male, well-controlled, hypertensive, no other comorbidities, presented with difficulty in passing urine. PSA was 300 nanogram per ml. Biopsy was, trust-guided biopsy was adenocarcinoma, Gleason score of 8, 4 plus 4. So Dr. Tamojit, at this point, if the patient comes to you, most of these patients will present to the urologist, but if the patient comes to you, what all investigations do you want?
Yeah, so basically I'll go for a radiologic investigation, predominantly one CMRI pelvis and one PSMA PET CT scan.
Okay. You are doing both, sir, at baseline with a PSA of 300, or you will probably choose PSA?
I'll do first the MRI. I'll do the MRI. Usually in our institute at Tata Memorial Hospital, Jamshedpur, we do MRI pelvis for a suspected CA prostate before biopsy, because that is as per guideline. So MRI ideally to be done before trust-guided biopsy or before an percutaneous biopsy. So here it is not being done. So ideally in CMRI pelvis, and followed by means depending on the findings, preferably one gallium 68 PSMA PET CT.
Dr. Vipinesh, any difference in opinion you would like to, or what are you following at your institutional practice?
Yeah, definitely MRI may be indicated, but if there are other symptoms for which the patient is, because most of the patient, initially these patients are seen by urologist and radiation oncologist, so mostly they are getting an MRI to see the local Ds, and after it, the PSMA PET to see if it is metastatic or not. So I agree with the opinion. And apart from that, sometimes if the PSMA PET is not there, then CT scan may also be there. CT scan plus bone scan may also be done.
Okay. Any difference in opinion, Dr. Rajesh?
I
Or
agree.
you're doing
Yeah.
PSMA first, followed by MRI, or MRI first, followed by PSMA?
No, ideally, like what Dr. Tamujit has said, we do MRI first and then biopsy. But if patient come with biopsy and with PSA 300, then I will do
Yeah,
a PET scan only first. And if there is a metastasis, then yeah, MRI can be
we can
avoided.
avoid.
Mm.
Yeah, I think looking at the PSA of 300, even at my place, if the patient comes, and I think most of us work in a center where getting a PET is much easier, much more viable for discussions also. And 300 very high chances of metastasis. I would do PSMA first, and if I feel that disease is only localized, then I think my decision making will lie on the MRI. But I think going ahead with the other approach is also absolutely feasible. So this patient underwent PSMA PET scan first. So he was found to have a large PSMA avid lesion involving the entire prostate, involving bilateral seminal vesicle. He had bilateral external iliac, internal iliac, common iliac lymph nodes, multiple bone mets, liver mets. So basically, widely metastatic disease. So again, question to you, Dr. Rajesh, what will be your treatment plan at this point? Anything else you would want to do? Any like we are now in the era of precision medicine. Any genetic testing at this point you will advise to this patient?
Yeah. In metastatic prostate cancer, we do HRR and MSI.
Yeah.
And
Okay. And what will be your choice of therapy, sir?
so many of time I don't change therapy in CSPC, metastatic CSPC, castration sensitive prostate cancer. In castration resistant prostate cancer only I am using, but yeah, on the breast tissue I will prefer to do HRR right now only. And
Right now.
MSI and yeah, germline hereditary cancer panel, at least for BRCA mutations.
Dr. Tamojit, what further investigation? Just a few words on investigation, then we'll discuss about the choice of therapy.
Yeah, so if we see the present EMA and NCCN and European Andrology Union guidelines, then you can always go for a baseline as discussed by Dr. Rajesh, baseline HRR and even NGS panel also. But the issue is these out of these results, none of the drugs are to be used in metastatic castration sensitive setting. So all these
Right.
drugs are actually approved in CRPC setting. So that is
Mhm.
optional. At least in our institutes, we are not doing mandatorily at the time of CRPC. Only we are doing that for the genomic panel. For the time being, this is a high volume, high risk metastatic disease, and probably before starting systemic therapy, usually we do a detailed cardiology workup, cardiac function testing, and as well as a baseline serum testosterone. These two we'll do before starting systemic therapy, and then we'll do the counseling regarding the doublet versus triplet toxicities and all other things.
Dr. Bipinesh, your opinion?
Yeah, definitely I agree with all the points. And one more point I would like to add is that in these patients in the castration sensitive setting, further at our center at Varanasi, we have a trial of saruparib also, which is a new generation PARP inhibitor. So maybe to improve the outcomes in that setting, I'll screen the patient for this trial. And because as we know, for all the patients, despite the high good PFS we achieve in the prostate cancer, still the patients, some of patients don't achieve optimum response. Definitely we should be looking to send the patient for any relevant trials if they are available.
Okay. So I think you have trial for upfront HRR mutated patients. I think which was that is what you
Yeah,
said, right?
yeah.
Okay, yeah, that is probably going to come into picture, at least in the HRR mutated setting. The results in the CRPC settings are really impressive. The Propel and Talapro will discuss briefly about that in the subsequent slides. But yes, it's nice to know that through this panel discussion that you have a trial. If there are some eligible patients, definitely we can seek your help. So again, the question: two drug versus three drug. How do you choose? Are you using it in your practice? Now, how frequently you are using three drug in your clinical practice? Like starting with Dr. Rajesh.
So if patient is fit, most of my patients are taking three drug. If patient is fit, and especially this high burden disease. So I'm more intended to use three drug versus two drug.
Are you convinced with like using three drug in all comer patients or just
No,
some select few?
In high burden disease, I am preferring to use 3 drug, and in low burden disease, if patient borderline, then I use only 2 drug.
How do you define high burden, sir? Like,
I'm
is it
using
your
the
clinical assessment,
yeah,
or is it
I'm
according to some of the trials?
no, I'm using like what we used in chartered, what we are using in chartered trial. Those things only I'm using.
Okay, Dr. Tamojit, any difference in opinion here?
No, fully agreed. So we used clinical criteria based on the chartered, or sometimes we can use high risk criteria for latitude also. But this is a patient with a high metastatic disease, predominantly visceral lesion in liver. So if performance score is okay, then preferred for a triple drug regimen.
Okay, and how about you, Dr. Bipinesh?
Yeah, definitely 3 drug regimen is preferred in the fit patients, but in my practice, in my opinion, I've had the experience of poor tolerability. So I usually, unless they're very, very fit, I prefer for the 2 drug regimen.
Yeah. So I think looking at this patient baseline IPSA, a lot of liver disease, uh, I think I would definitely see if the patient is fit. I would definitely opt this patient for, because the results of both Peace One and I think it was Arsen's trial, the results of both of the trial are very good and really convincing. Even though we're often in a fix that if the patient progresses on this therapy, what next to be used, we often think about the sequencing, that we are losing out on one of the options if you're using all the drugs together. But as we know that there could be a lot of attrition also after progression on first line. We do see that around 20-30% patients do get attrition. So I think it is always better to have to utilize all the best treatment options upfront, rather than saving it for later. So if the patient does present with visceral disease, a lot of polymetastatic disease, fit patient without much comorbidities, even though the control arm involving the NHS has not been there, it is always the docetaxel which has been used. But still, I would like to use it. But this, anyways, moving on. So upfront HRR testing, I think we have discussed. So they had this question. I think most of you are doing it. I think a couple of you said that it is optional, and I think Dr. Rajesh has a trial at the center, so he's, I think, doing it for all the patients. Uh, so this patient was treated. Suppose you have to use a doublet agent. This patient was presented in 2019. So what would be your choice of the second agent along with ADT? Again, anybody can take this question. I think Dr. Tamojit can take this question.
2019, I believe ADT along with 6 cycles of docetaxel 3 weekly regimen. That time it was the most common. Nowadays we have tablet data for abiraterone and enzalutamide also along with ADT. But still
Hello, hello. Is Dr. Tamojit audible?
No, he's not.
I think. Okay, Dr. Rajesh, I think you can take this question.
So
If you
yeah,
have to use a second agent, what is your choice at this point? We have discussed about 3 drug. If you're opting for 2 drug, what is your choice, and how do you
so
take that decision making?
yeah, if I'm opting for 2 drug, I'll go for a chartered based on high risk, high burden disease, and if patient is fit, I'll give docetaxel along with ADT. That was the
Uh,
standard for a longer time since chartered to
you're
peace.
not a big fan of abiraterone, sir.
No, but here it is a high burden disease. There is a liver metastasis, multiple bony metastasis. So chemotherapy would have been better here.
Okay, Dr. Bipinesh, your opinion on this?
Yeah, again at our center we have a investigational trial of docetaxel with low dose versus high dose abiraterone. So I usually send the patient for the study, and so abiraterone
सर
is
ट्रायल को छोड़ देते हैं सर, ट्रायल के अलावा बात करते हैं.
yeah, that's what. So abiraterone mostly is the preferred.
Personally, I also prefer abiraterone a lot. Uh, uh, but choosing any of the options, I think if you follow the NCCN guidelines, they don't recommend docetaxel upfront for all the patients as a category 1 now. They're opting for anybody for darolutamide. We do have The another trial by the same Arsens group, which had published the 3 drug versus 2 drug. Anybody for darolutamide? Are you convinced with the darolutamide data in the hormone sensitive setting? Dr. Samojit?
Am I audible?
Yes, sir, you are audible now.
So darolutamide plus ADT as the doublet agent in first line metastatic CSPC is still not category 1. Darolutamide
Yeah,
is only category 1 as a triplet regimen along
yeah,
with
it is.
docetaxel. So only
Now,
ADT plus darolutamide is not category 1. I'll not prefer that.
yeah, although we do have a JCO published trial for darolutamide in combination with ADT in the first line setting. Dr. Rajesh, any opinion on that trial that where they assessed darolutamide upfront?
No, no, I agree with Dr. Tamojit, and I have never used this drug yet.
Okay, Dr. Bipinesh,
Yeah,
any difference?
we have been using darolutamide as a second agent along with ADT with docetaxel.
Yeah.
But in our
Mhm.
experience, the dose of 600 mg BD is poorly tolerated with respect to fatigue and diarrhea. So mostly, after the patient tolerating docetaxel well, we start from the second cycle, and in a few of the patients, we had to reduce the dose and stop. So toxicity is an issue, but definitely the data is quite reasonable to start on the darolutamide.
Yeah, so it's quite interesting. There was a recent commentary that was published in JCO. I think it was published by one of my colleagues only. He was at AIMS. He's currently working at Princess Margaret. So he highlighted a major flaw with this trial that this darolutamide dual agent study was done by the 80% of the PIs of this study were of the same group which published the 3 drugs, daro plus docetaxel. And surprisingly, they have taken the control arm as ADT alone. And they have justified that in the real world setting, 40-50% of the patients are upfront are treated with ADT alone. That is why they have taken. It's quite unethical when we have data for COU 302, Charted, Latitude, Enzamet, which suggests that 2 drug is better than it is leading to improved survival. How can you choose a control arm as a ADT alone in this era? So I think that trial, that is a major flaw with this trial, and it is quite surprising that they have utilized control arm as a docetaxel plus ADT in their Arsens trial. They're the same PIs. So that is why probably I would not like to use darolutamide upfront just as a one agent. If I have to combine with dosi, we have good data, but darolutamide alone might not be a very good option at this point. So, anyways, just moving on. So, any difference in Enza EPA versus abiraterone, and how well you guys have accepted the oral GnRH analogs, the GnRH antagonist, which have come now. Anybody can take this question. Dr. Tamojit, maybe you can both the
So
questions.
relugolix I have not started as of now. Few of our urologists, uro-oncologists of our center have started. Probably
Right.
it is a better choice for them because it's a purely oral agent. And we know that data from the HERO study, which is suggested that it is actually in terms of achieving a castration level of serum testosterone, it is absolutely non-inferior to leprolide in metastatic CSPC. So regarding data, regarding side effect profile, it's perfectly okay. Although bit GI toxicity is higher with relugolix, but as of now, I have not started using, but few of our uro-oncologists have started to use it. Regarding your next question,
Abira Enza versus APA.
Yeah. So nobody can give a robust answer which is the best drug in this setting, because we know that these are all category 1 recommendation. If we focus on the current NCCN 6 cycle of docetaxel plus ADT is as of now is not a category 1, which was during our
It is
DM
not.
days, which was probably the best option, the time tested option. But so
Right,
as of now, the
right.
category 1 recommendations are either ADT along with some sort of either means testosterone enzyme
NHAs.
inhibitors or second generation androgen receptor inhibitors. So regarding that, a few of my patients I have started with ADT plus Enza upfront, particularly to avoid cardiotoxicity of abiraterone, particularly in very extremely aged patients, and they tolerated well. So I have never used apalutamide as a first line. 2 of my patients are on apalutamide, but those are the patients who have not achieved a good PSA reduction after 3 months of abiraterone, and then we have switched to apalutamide. And means interestingly achieved a good PSA reduction. But otherwise, I usually start either abiraterone or enzalutamide, but depending on their patient's comorbidities, because we know that the cult toxicity of abiraterone is sometimes unacceptable for this elderly population.
Dr. Rajesh, any difference in opinion, or you agree with what Dr.
No, I
Tamojit?
agree with Tamojit, Dr. Tamojit. I have also not, I'm not comfortable much in using this oral relugolix because of adherence issue. And
Yeah, absolutely.
rest is what he told. I agree with him.
Dr. Bipinesh?
Yeah, nothing much to add in this topic.
Yeah. So I think most of us, I think, choose these drugs based on their toxicity profile. Discussing another thing which I would like to highlight, that particularly patients who are 70, 75, if you're starting these patients on upfront ADT, a lot of these patients present with urinary symptoms. Already there is urinary stasis is there. If you add steroid also, which is usually needed with abiraterone, I have seen personally experienced more UTIs in the first 3, 4 months. Somehow that is there. So if the patient is very elderly, weekend frail, I prefer to go the Enza way, where I can avoid the uh, so I think we have answered this, that docetaxel upfront. I think more of a logistic now. It's not a category one recommendation anymore. And majority of the patients, if you, I think, give the options that chemo versus non-chemo, they will definitely opt for non-chemo unless you are going the free drug regime upfront. So anyways, this patient was started on degarelix plus valronic acid, abiraterone. So PSA nadir of 0.02 gram was achieved in 6 months. Is PSA nadir important to you? What are you looking when you are starting treatment, Dr. Tamojit? Do you look at PSA nadir or the rate of decline of PSA fall and take your treatment decisions, or it dictates anything? I think we can't hear him. Dr. Rajesh, you can take this question meanwhile.
Actually, I'm not looking for PSA Nadir, and I'm not changing based based on PSA Nadir report my treatment. If PSA is declining and patient is doing well, then I'm continuing treatment same.
Dr. Bipinesh, any role of PSA nadir otherwise? I know we will not change our treatment decision making, but any role of this?
I'm not specifically aware of any such point.
Okay, so interestingly, data was published in ASCO GU last year that if the patients were treated with abiraterone plus this ADT, if they achieve a PSA nadir of less than 4, their median PFS was almost nearly double as compared to patient who did not. And there is recently published data, I think it is in Nature or some journal, where apalutamide initially treated patients also, where a PSA nadir they have divided into low, ultra low. If low or ultra low values are achieved, those patients prognostically generally do much better as compared to this. So as sir was mentioning that in 3 months, 4 months, even if you have not achieved a very desired fall in the PSA, you should be worried. Maybe if you've started on 2 drugs, maybe consider adding chemotherapy to the regimen. So anybody is doing repeat PSMA PET CT as a response assessment, we are treating the patient, PSA is falling down. A lot of patients they come with this apprehension that डॉक्टर साहब PET scan नहीं किया आपने हमारा की response आ रहा है नहीं आ रहा है. Dr. Tamojit, are you doing? Dr. Rajesh, anybody?
Audible? Am I audible?
Yes, sir, you are audible now, sir.
Yeah, so if baseline PSM PET CT has been done for a baseline workup, then it is always preferable to do a PSM PET CT if money is not a concern. But the major issue is there is no university accepted response evaluation criteria for a PSMA PET CT.
Yes,
That is the
right.
major thing, because you want to use a modified resist for prostate, you want to use a PO resist, you want to use a persist criteria. We really don't know. There are a lot of other, if we read recent nuclear medicine journals, then there are at least 6 different response evaluation criteria which are being used in major trials, and we really don't know that what is probably the best. And at the same time, our nuclear medicine specialists are also not knowing this answer. So that is the major challenge. But for the time being, if money is not an issue, and if PSA response is sometimes we see that PSA reduction initial 4 months, 6 months, PSA reduction is good, but from a level of 300, 400, PSA gradually decline to 10, 15, or 20, and after that there is a plateau. So that is probably the major challenge. And that time, sometimes after achieving plateau, and if there is no further reduction for next 2-3 months, sometimes we repeat PSMA PET CT to detect whether there is an early progression or new appearance of any visceral disease. But there
I
is no
think
right answer to this question, I believe.
we also gave this as a thesis to one of our students, our DNB students, that rate of PSA decline and persist evaluation, and there was a major mismatch. Although the sample size was very small, but there was no correlation with the PSA persist response assessment and PSA decline. So I agree with you that these response evaluation guidelines for PSMA PET scan is quite sketchy. So so this patient again, I think just I'll conclude with this case only. I had made a slide for oligometastatic disease as well, but I think this is more relevant because we don't have panels of radiation and surgeons. This patient presented with PSA of 9.2, PSMA PET CT again, progression at few bony sites, few PSMA avid nodules. So how do you sequence your therapy? If the patient has been treated with abiraterone, what will be your choice of agent here? Quickly with everyone, Dr. Bipinesh.
Yeah. Yes. Again, as we have been, we know that from progression, we don't give if we have been given an oral ARPI, then we switch to chemotherapy, or if we're given a chemotherapy, then we switch to a oral agent, so that there is some gap, and then the next agent can be changed. So if the patient received abiraterone, we'll switch to docetaxel, and then the patients who are given dual or triplet therapy, definitely in that we have seen that the addition of again in patients who are quickly progression on dual therapy, uh, the entity called AVPC, aggressive variant prostate cancer, we should be aware to look for that. So maybe we can do IHC of P53RB, and one more I'm not able to recall. That is always on our mind. And definitely the regimen of cabazitaxel plus carboplatin will be on our mind if there is a rapid progression. Otherwise, the other, as I told, the switching from the chemotherapy to ARPI will be the preferred option.
Dr. Rajesh, would you choose Enza for this patient, Enza or apalutamide for this patient?
No, I would prefer chemotherapy. Patient has received hormone therapy initially.
Right, right. I think we have had data. I think phase 2 data is there that if you single arm phase 2 data is there. If you switch NHAs, I think the response rates after abiraterone progression is just decimal 15%, and after Enza, if you add abiraterone, the response rates are virtually 0%. So I think most of us will opt for chemotherapy. Anybody would like to place lutetium here? CRPC now it's an approved therapy. And what's your experience that if you're exposing the patients to chemotherapy and then you're utilizing lutetium, do you face more toxicity? Where do you place lutetium at this point? Our center is a very high volume lutetium center. So we've got a good experience of using lutetium at upfront progression on first ARPIs. But what is your experience? I think with some of these.
Lutetium-based therapy can be considered for this patient, especially if it is showing very avid PSMA.
Yes, sir.
And post multiple lines of therapy, patients stop taking PSMA uptake also. Many times disease is progressing,
Right.
but PSMA uptake will not be there. And those are not ideal patient for PSMA therapy. And if uptake is good, then we can send patient upfront only.
You made a very, very valid point that as
Only
you
for PSA
expose the patient to more lines of therapy, they are with 4 or 5 lines of therapy, there is always some endocrine component lurking behind, and probably those are not the very best candidates to treat with. And we know from data that there is a 40% lifetime risk of development of neuroendocrine carcinoma in a resistant prostate cancer patient. So I also feel that, and my personal experience, if the patient have been heavily pretreated, majority of patients end up requiring some form of radiation as a palliative setting. So those patients tolerate lutetium very poorly if you're using it at third line, fourth line. So probably I think there is no head-to-head data, but if I have a patient who's 70-year-old, where I'm afraid about chemotherapy toxicity, I would probably utilize after ARPIs. I would probably utilize lutetium before docetaxel. Dr. Rajesh or Dr. Bipinesh, any difference in opinion? I know it's very hard to answer this question based on any randomized trial data, but just personal experience, I would like to listen.
Yeah, I have started sending patient in upfront progression, especially when we are using triplet. We have given docetaxel, abiraterone, and then patient progress. Then showing PSMA uptake, I will send upfront for PSMA therapy.
Great, sir. Dr. Vipinesh, your opinion?
Yeah, at our center also we have a good nuclear medicine facilities, but most of the time is sent on at the early stage. They because of cost issues or other issues, they prefer it for the third line or later only. And definitely hematological toxicity is a big issue with the radiation therapy. So they keep a target of around 8 hemoglobin. Sometimes it's difficult to achieve in the patients who are heavily pretreated.
Yes. Even bad like bone marrow suppressants are things which have required like almost 3 months to recover. So that is always a challenge. So particularly patients with very heavy bony disease, we have seen that the bone marrow toxicities are slightly higher. So just last question, I think, then we'll wind up. Opinion on PARP inhibitors, olaparib, talazoparib in CRPC setting, single agent versus combination. How happy are you with the Profound trial? How happy are you with the data of Profound trial? Starting with Dr. Tamojit. Dr. Tamojit, I think you are muted, sir. Uh, Dr. Rajesh, I think no, we have lost Dr. Tamojit voice.
So
Dr.
those patients who harbor this HRR or BRCA mutations, they eventually do worse. They do not their prognosis is poorer compared to other
Yes.
patients. So
Yes.
whatever we use, they will not do well. Now, if patient is HRR positive or germline BRCA mutated, then yes, we'll use the olaparib or talazoparib in CRPC setting, and post second line or third line. And if patient has not received abiraterone initially or he has not received hormone therapy, then we can combine this PARP inhibitor with hormone therapy also.
Yes, if patient has been treated initially with docetaxel based on our Propel data. Dr. Bipinesh, what is the major flaw with the Profound trial data? What was the major flaw that you face, and are you comfortable with the data that was presented?
I don't exactly remember, but definitely in my practice, I'm not very comfortable with the single end because the PFS difference was not very great. But I don't remember exactly the data.
So actually, in the control arm, they have used a switch NHA. So, if the patient has progressed on abiraterone, they have used enzalutamide. If the patient has received enzalutamide, they have used abiraterone. So, we know that it's a very flawed control arm. And based on the results of cohort A, they have published the data for the entire cohort. So, just cohort A patient are doing well, and that too, I think that entire PFS data is driven by BRCA2 mutated population. It's the BRCA2 population which do really well. Apart from that, if you dissect the data for other mutations, the numbers are small, but the results are not that great. So I think single agent probably will go out of the picture in coming years. HRR mutation is there. There is also a theory to suggest that if you combine it with Birateron or some of the newer hormonal agents like talazoparib, or I think we also have data coming up for rucaparib in CRPC setting, the results are going to be superior. So I think it's already 9 o'clock. With that, I would like to wind up. If anybody has any comment, any panelists have any comment, we can comment. They are welcome to say something. And there were some more slides on oligometastatic prostate cancer, but I think we'll leave it to some other meeting.
Thank you, sir. Thank you so much for the excellent panel
Thank you, Dr.
discussion. And thank you to our panelists, Dr. Tamojit, Dr. Rajesh, sir, and Dr. Bipnesh, sir. Thank you all so much. So as we move forward, I would like to invite Dr. Bipnesh, who is Associate Professor Medical Oncology at Mahatma Pandit Madan Mohan Malviya Cancer Center and Homi Bhabha Cancer Hospital, Varanasi, for the talk on ASCO GU 2025 recap. Over to you, sir.
Can you please share the slides I have shared with Samar?
Yeah, sure, sir.
So, as we
Slides
are
are visible?
not yet. Yeah, now it's visible. Yeah, so the slides are visible. Yeah, so as we are already short of time, and anyways, the topic is a quick recap of some of the relevant trials in the ASCO GU. So I'll quickly do a recap. So yeah, the slides are visible, so I'll start. So one of the studies was the POTO study, in which the it's a genomic-based signature on for the radiotherapy patients. So based on the previous dose response in the earlier trials like SAC and NRG, this score was developed based on genomic signatures of hypoxia and immune response, and it can be used to guide radiation dose escalation or de-escalation. But limitations were at that time no AT was used and the PSM PET was not used in many patients. So further studies are required in this setting and which are being done. Next slide, please. Yeah, and so again, radical prostatectomy versus radiotherapy in high-risk prostate cancer. Individual patient-level data was from two phase 3 randomized trials was presented. Next slide, please. Yeah, so the key takeaways from this were that since both are equally acceptable alternatives, so radiotherapy-based treatment regimen appears to result in lower incidence of distant mets than a surgery-based regimen for patients enrolled on in these studies, and approximately 80% of patients with high-risk prostate cancer treated with surgery will receive further treatment or experience recurrence. And adjuvant early salvage RT remains critical for this population, and the use of the triplet quadrat therapy of neoadjuvant chemo AT and radio and this radical prostatectomy and personalized post-op RT AT mitigate these differences. And further trials are again differently indicated in SPCG 150 and such an trial in this group of patients. Next slide, please. Yeah, so again, coming to the immunotherapy part in the GU, so we had a study of durvalumab in combination with neoadjuvant chemotherapy, gemcitabine or carboplatin in patients with upper tract urothelial carcinoma. So we know these patients are rare, but not so rare also. Next slide, please. So in this is the first neoadjuvant phase 2 study with very good safety and encouraging results in terms of residual disease, particularly when cisplatin is used. And as we know that cisplatin definitely makes a difference compared to carboplatin. And further phase 2 study of INDEC 3 is ongoing, and definitely we are excited to have one good option for upper tract urothelial carcinomas, in which the number of options are limited. Next slide, please. Again, high-dose chemotherapy in testicular cancer. Again, this abstract was presented, and we know that this has been on our mind since quite a bit of time. Next slide, please. So we know that it is effective salvage therapy of patient relapsicity, and on the definitely the data which is coming, it shows that it can lead to cure in patients with platinum refractory mediastinal non-seminoma and patients with third line therapy and progressive brain mets, and caution with borderline conventional tumor markers and sanctuary sites like testis and brain is recommended. And definitely further the data is awaited, and MRD post high dose chemotherapy, biomarkers and maintenance therapy for this further data will be required. Next slide, please. Yeah, again, we have been discussing this topic, metastatic hormone sensitive prostate cancer, which patients benefit more from androgen receptor pathway inhibitors. Again, this is a stopgap meta-analysis of individual patient data. Next slide, please. Um, you can skip the slide. Next slide, please. Yeah. So again, the RP lymph node resection patient stage 2 seminoma management strategy and current controversies. So again, for these stage 2 patients, there are certain options like chemotherapy and surgery. So again, in this data is presented. Next slide, please. So in this study, the open RPLND, we know that this is a very good option in the low volume clinical stage 2A/B marker negative pure seminoma, and is associated with minimal surgical associated morbidity, and 100% cure can be achieved for the some amount of patients, like 10 to 30% of patients, relapsing patients with salvage chemotherapy. And the major benefit of this is that avoidance of long-term toxicity due to standard treatment with the chemotherapy regimen, BP, 3 cycles, and or retroperitoneal RT. So definitely this is a one thing where toxicity, as we know that with high cure rates for seminoma, we need to escalate the treatment. So definitely this is one data where further studies and further analysis of data will be required. Again, next slide, please. Yeah, yeah. So again, this was again discussed at various forums. The Cosmic 313 study of cabozantinib in combination with nivo-ipi in previously untreated RCC. Next slide, please. Yeah, so in the final results, at 45 months of follow-up, the first line treatment with this immuno combo with Cabo continued to demonstrate PFS benefit over placebo, and there is no significant OS yet, and the safety profile was definitely consistent with the previously reported trials, and exploratory immune cell and machine learning model identified some of the patients which with the certain immune signatures which may benefit more from this combination. Further data is awaited for this study. Till then, definitely this is one of the option, but not toxicity. This might not be suitable for all patients. Next slide, please. Yeah, again, so the Nemo plus cabozantinib, which is a very acceptable treatment for advanced RCC, compared to sunitinib for previously untreated RCC. The final follow-up periods of CheckMate 9ER trial. Next slide, please. Yeah, so the long-term efficacy was observed with this regimen over sunitinib, with the median of 67.6 months of follow-up, and with the long-term follow-up, this regimen continues to establish itself one of the preferred standard of care for patients presenting with this setting, and with the availability and expected availability of subcutaneous nivolumab, this is further going to be very beneficial for patients who who are surviving for a long time with this immuno and TKI combination. Next slide, please. Yeah, again, so on the MIBC setting, high risk adjuvant nivolumab versus placebo, additional efficacy including OS results were reported for the patient from CheckMate 274 study. Next slide, please. Yeah, so with the extended follow-up in this study, adjuvant nivo continued to show DFS benefits for patients in the MIBC regardless of prior treatment, and OS data from the interim analysis also favored nivo over placebo in all patients, and no new safety signals were identified. And the improvements demonstrated in the patient with MIBC provide additional support for adjuvant nivo as a standard of care for high-risk muscle invasive urothelial carcinoma, including MIBC after radical surgery, regardless of prior treatment. Next slide, please. Yeah. Again, the Niagara trial, which I also discussed today. So additional safety and efficacy and safety outcomes on exploratory impact of the pathological complete response were discussed. Next slide, please. Yeah, so it demonstrated clinically meaningful EFS with a 10% improvement in the PCR rate, and the risk of an MFS event was reduced by 30%. And so definitely perioperative durvalumab improved EFS and OS in both PSR and non-PSR groups in the exploratory analysis, and the adverse effects were quite manageable. And this further supports the use of perioperative durvalumab with neoadjuvant chemotherapy as a potential new treatment for patients with cisplatin-eligible MIBC. Next slide, please. Yeah, next slide, please. Next slide. Yeah, so again, the Keymaker U03 study, in which pembrolizumab and targeted therapy combinations for advanced clear cell RCC were studied. Next slide, please. Yeah, so in this study, again, the vast majority of patients received 2 or more prior rounds of chemotherapy. And again, belzutifan, which we know has been approved for patients with the VHL mutations in any of the cancer, along with differently for RCC. So this combination of lenvatinib plus belzutifan showed a numerically higher ORR of 47% and a median PFS of 12.5 months. And definitely this the data from the LightSpark 005 study where the results from the pembrolizumab plus belzutifan were similar to that observed in the belzutifan study. And this pembrolizumab plus lenvatinib also showed high anti-tumor activity in this population. And so differently, the results from this study show that lenvatinib plus belzutifan is a good combination. And definitely, so we know that in RCC we have good first line and second line regimens, but post second line regimens, despite the various sequencing strategies, patients don't do very well. So definitely with the availability of belzutifan, we might have a better option for the further treatment line of these patients. Next slide, please. Again, so PSMA-based therapy in advanced stages, touching on the combinations and sequencing. This was presented in the ASCO GU. Next slide, please. Yeah. So definitely, as we have just now had in the panel discussion, that lutetium 177 PSMA are a very promising new class of treatment, and the synergistic effects of this treatment with others are being explored for better outcomes in various settings, particularly CRPC, where the despite advances, the patients don't do very well. And differently, this research on the moving it up in the further early settings of treatment will be helpful. And so these data is presented. Next slide, please. Again, this we know that quality of life is also very important for these patients with the elderly male, and definitely in many of the times the quality of life is not touched upon very times. So this study studied the impact of salvage therapies on this aspect of the treatment. Next slide, please. Yeah, so the conclusions were that QL should be standard components of all treatment decisions, and patients reported QL in existing trials suggest that systemic therapy has mild to moderate impact, but we may not be measuring what really matters. So because many of the times we are going for the PFS and OS, but for when there is a very small difference in PFS and OS, definitely QL has to be taken into account. And even though if whether it is small or large, in all aspects QL, as we know, for patients surviving a longer time of them, QL is very important. And definitely this studies this shows that QL should be interventions and measurements should be offered to all patients irrespective of their disease stage and evolution in the treatment course. Next slide, please. Yeah, thank you. Thank you. So back to organize, and thank you for inviting me.
Thank you, sir. Thank you so much for the excellent talk. And thank you, everyone, for joining for today's webinar. Thanks to all the speakers, all the panelists, and thanks to my colleague Dhruv and Samar and the technical support team. Thank you, everyone. Let's meet tomorrow at the same time. Good night, everyone.
Thank you.